Hey guys, it's Kathleen. Talking today about diabetes, and we have a lot to cover. And it's a great lecture. We're going to be managing lots of patients with diabetes in your practice. So, diabetes, by definition, is a medical disorder of carbohydrates, fat, and protein metabolism, characterized by elevated blood glucose levels due to inadequate insulin production or impaired insulin action. There are type 1 diabetes, which is juvenile diabetes or insulin dependent, and this is caused by beta cell destruction, which leads to absolute insulin deficiency. It can be immune mediated, which is caused by pancreatic destruction, or it's idiopathic, meaning they don't know the cause of what causes type 1 diabetes. Type 2, adult onset, non-insulin dependent, and this is caused by insulin resistance and impaired insulin secretion. And I'm going to just talk a little bit about, or just in another, the third type of diabetes is gestational. Also with gestational diabetes, after, that means while they're pregnant, they develop diabetes. But know that if they develop diabetes gestationally, you always want to monitor them after the fact, because that puts them at risk for developing diabetes. So if you take a specific piece of paper out to write down notes, this is just a review from Patho, but it's important to understand insulin resistance. And basically, insulin resistance occurs because you have an increased carbohydrate diet that's over a period of time. So carbohydrates break down sugar, so if you have an increased carbohydrate diet, you need more insulin. At the same time, when you have the increased carbohydrate diet over a period of time, your cells react to the increased insulin levels by making fewer insulin receptor sites and decreasing the number of sites available. This happens over time, and this causes your cells to stop responding to insulin adequately, and therefore you develop insulin resistance. Hyperinsulinemia. Yeah, hyperinsulinemia. Oh my goodness. Hyperinsulinemia, sorry guys, is most often caused by insulin resistance. So you get insulin resistance first. Hyperinsulinemia, oh my God, is a condition in which there are excess levels of insulin circulating in the blood than expected relative to the level of glucose. While it is often mistaken for diabetes or hypoglycemia, increased levels of insulin can result from a variety of metabolic diseases and conditions. While hyperinsulinemia is often seen in people with type 2 diabetes, it is not the cause of the condition. It is only one symptom of the disease. Hyperinsulinemia is associated with hypertension, obesity, dyslipidemia, and glucose intolerance. These conditions, hyperinsulinemia, hypertension, dyslipidemia, and glucose metabolism intolerance, glucose intolerance, are collectively known as the metabolic syndrome, and there's close association. Again, hyperinsulinemia is most often caused by insulin resistance, and insulin resistance is a condition in which the body is resistant to the effects of insulin, and your pancreas tries to compensate by making more insulin. A pathogenesis of type 2 diabetes is dysfunction of insulin secretion, overproduction of glucose by the liver, and reduced glucose uptake and utilization with type 2 diabetes. Again, what happens is you get insulin resistance, which leads to hyperinsulinemia, which leads to the impairment of glucose stimulated insulin release. And some of the factors are genetic and environmental, which causes an impairment in insulin-mediated glucose uptake. What happens is initially, the fasting plasma glucose levels remain normal in the beginning. However, postprandial plasma glucose levels rises. So that's the blood sugars after males rise. Increased glucose leads to glucose toxicity, and glucose toxicity is really the cellular dysfunction that occurs with chronic hyperglycemia. And this causes a decline in the capacity of the beta cells to secrete insulin. With increased insulin resistance, fatty acids no longer are restrained, and then you have an increase in fatty acids, which causes a further increase in insulin resistance, which becomes a vicious cycle that leads to fasting and postprandial hyperglycemia. And postprandial hyperglycemia is a spike in blood sugar right after meals. The scope of the problem. The prevalence is 18.2 million, which is about 6.3% of the population have diabetes. 13 million are diagnosed, whereas 5.2 million are underdiagnosed. 92 billion a year as a result of long-term complications of diabetes is spent on diabetic complication, and this does not include costs associated with medications or other disabilities. Increase in incidence and prevalence of the disease. 40% of older people are insulin resistant, and this is mostly secondary to obesity and inactivity. And this is important in the prevention and treatment of diabetics. 20% of the elderly have type 2 diabetes, and 8.5% of the adults have type 2 diabetes. 90% of diabetics are managed in primary care setting. There's a lot of social and economic costs of diabetes. There's a high morbidity associated with the disease. And there's a number of underlying patients with diabetics that are undiagnosed, and the effects of inadequate treatment on the disease, which is undiagnosed or inadequate treatment of the disease, which causes worsening comorbidities. Risk factors for diabetes: family history of diabetes, glucose intolerance, race is also a risk factor: African American, Asian, Hispanic, Native American, or Pacific Islander. Age over 45 is a risk factor for diabetes. Physical inactivity, obesity, gestational diabetes, and metabolic syndrome. Signs and symptoms of diabetes are polyuria, polydipsia, polyphagia, blurred vision, fatigue, sores that heal slowly, recurrent infections, vaginitis, yeast infections, and UTI, which if you're doing women's health, again, if a woman has a lot of yeast infections, check her blood sugar, okay? Type 2 diabetics may have a subtle presentation. However, they still have the same long-term vascular and neurologic damage. So we have to screen. And so polydipsia is excessive thirst, and polyphagia is excessive hunger. Signs and symptoms of cardiovascular signs and symptoms of diabetes are diminished or absent pedal pulses, decreased capillary refill in the nail beds, pretibial edema, cool extremities, neurologic, sensory loss, absent knee and ankle, deep tendon reflexes, defects or deficiencies in extraocular movement. In the eyes, you have damage to nerve controlling extraocular movement, which causes the defects in the EMOs. In the eyes, you'll have retinopathy, including microaneurysms that are seen with ophthalmoscope, cotton wool exudates, neurovascularization causes the cataracts and glaucoma. Also, when you look at eyelids with long-term diabetics, you're looking at ptosis, which can damage the nerves, which control the upper eyelid. So look for that. Oftentimes you'll see that with chronic diabetics. Screening. United States Preventative Services Task Force, USPSTF, states that there is insufficient evidence to recommend for or against screening. They recommend screening adults with hypertension and hyperlipidemia. There's insufficient evidence to recommend for adults against screening. But, you know, your gestalt, if you have an overweight person, a family history that you could put in your history to warrant that blood sugar or the screening. American Association of Clinical Endocrinologists state that individuals greater than 45 and above recommend repeat every 3 years, younger age or more, frequently. If they're overweight and they have a BMI greater than 25 and they have additional risk factors, you need to screen them. If they're physically inactive, first-degree relative with diabetes, race, gestational diabetes, they delivered a baby that was greater than 9 pounds, they have an HDL of less than 35 and a triglycerides greater than 250, they have polycystic ovarian syndrome, they have impaired glucose tolerance or an impaired fasting glucose on previous tests, they have a history of vascular disease, and they have clinical conditions associated with insulin resistance, which would be obesity, physical inactivity, hyperlipidemia, hypertension. Assessment. So your pertinent history is present health, family history, past medical history, psychosocial history, and the exam is pretty much a full exam, vital signs, height, weight, ophthalmic exam, thyroid exam, cardiovascular exam, lung exam, neurologic exam, abdominal exam, vascular exam, and skin assessment. Diagnostic tests. Initial test is a fasting plasma glucose, a hemoglobin A1C, a fasting lipid panel, renal function, urinalysis, including microalbumin, and EKG, if indicated, TSH and urine culture. Microalbumin should be measured on a yearly basis for a diabetic. And if the microalbumin is elevated twice on a random urine sample, you want to collect a 24-hour urine. Okay, so these are hypertensive goals. These are a little outdated. You are going to follow the hypertensive new guidelines, which is the goal is less than 140/90, which I talked in depth on. There is no study that states if you have diabetes that bringing them down to 130/80 is the best deal. So it's 140/90 if you're under the age of 65 and you're between 18 and 65. Decreases all complications. That means if we have good control of their blood pressure, they're at decreased risk for death, CVA, CHF, and microvascular changes. Coronary heart disease is the leading cause of death in type 2 diabetics. We want to minimize contributing factors. We want to use aspirin, get them on aspirin. The goal is to decrease triglycerides, LDL, and increase HDL. Nephropathy, we want to protect the renal function, and how we do that is we control the hypertension, the dyslipidemia, and the diabetes. For the eyes, the retinopathy, we want to control the hypertension and diabetes. Here are the normal prediabetes and diabetes. For a random blood blood glucose level. If you have a random blood glucose level of 200, you have diabetes. If you have a fasting plasma glucose greater than 126, you're a diabetic. If you have an oral glucose tolerance test greater than 200, you're a diabetic. You need to know the normals, less than 110 for a fasting plasma glucose test is normal, and an oral glucose tolerance test is less than 240 in 2 hours. And anything under 200 for a diabetic, for a random blood glucose level, is not considered diabetes. So also with hemoglobin A1C, normal is 5, pre-diabetes is 5.7 to 6.4, and a diabetes is 6.5. A lot of the endocrinologists say that an A1C of less than 7, a hemoglobin A1C of less than 7 is what we want for patients with no cardiovascular disease and no they have a long life expectancy. So we want patients' hemoglobin to be less than 7. We will look at hemoglobins. We will control patients and make their goal hemoglobin A1C 8 to 8.5. And these are patients with limited life expectancies, advanced micro and macrovascular problems, extensive comorbidities, patients who have a history of hypoglycemia, or patients with a long-standing history of diabetes in whom the general goal of getting it under 7 is difficult to attain. Diagnostic tests for an established patient with diabetes: you want to do a complete physical exam, lab test as indicated, hemoglobin A1C every 3 months to annually, fasting lipid profile annually, BUN and creatinine annually, urinalysis, urine for microalbumin, and again, if there's proteinuria, you perform a 24-hour collection for creatinine clearance. Referrals: a dentist, ophthalmologist, dietitian, podiatrist, and you want your patients to get a flu shot and a pneumonia vaccine. These are really important. As your primary care provider, you're going to be looking in the medical record. You're seeing this in clinical now, making sure the providers are making sure they have their ophthalmologist documented the time. Ask the practices how do they ensure that these patients get them. Who follows that up? Is it the provider? Is it the medical assistants? Is it the secretary who makes sure to let you know that this isn't followed up? Because you as the provider should be looking at the referrals from the ophthalmologist, the podiatrist, the dietitian, and incorporating that into your annual report and physical for them. I'm writing something that you saw that you read the ophthalmologist report, what they recommend, and this is, the patient is following this, blah, 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 blah. American Diabetes Association, hemoglobin A1C less than 7, preprandial plasma glucose 90 to 130, postprandial plasma glucose less than 180. These are goals. Blood pressure less than, again, it's 140 over 90. Forget the 130 over 80 and 125 over 74. Those were old. But it's interesting and to actually see the comparison. LDL is less than 100, HDL greater than 40, and triglycerides you want less than 150. And again, the LDL is really percentage. Whatever the LDL is, we want them to be lower, at least 50%, with the specific statin we choose based on the patient's presentation. The clinical endocrinologist, they're more stringent goals. Hemoglobin A1C of less than 6.5, which they're not doing. The endocrinologist right now, it's just what I had repeated to you before, is 7. Okay, so hemoglobin goals of 7, fasting plasma glucose target of less than 110, and then postprandial 2-hour glucose target of less than 140. But oftentimes there's a new study coming out which hasn't been published yet about the postprandial 180, and I'll clarify that as well. So just stick right now with the postprandial plasma glucose of less than 180, and I'll let you know about the new endocrinologist study about the less than 140 after eating meals. We're going to talk more about that, and I'll give you a supplemental YouTube video on a study, a couple studies that have been done that haven't even been out yet. Okay, so this is your hemoglobin. So here's your hemoglobin A1C 14. So you have average blood sugar in the last 3 months of 360. So what you should be normally is 5, which is an average blood sugar of 90. This is diabetes, 6.5 to 7. And then we have different goals depending on, what your medical comorbidities are. You have a goal of a hemoglobin A17 to be less than 7. If you're very sick with limited life expectancy, it's 8 to 8.5, okay, which is a blood sugar of 180 to 195. Hemoglobin less than 7 is a blood sugar less than 150. The 8 to 8.5 is patients that have a history of hypoglycemia. That's where you're going to have them a hemoglobin A1C to 8 to 8.5 because they have a history of hypoglycemia. So nephropathy treatment of complications, you want these patients to be on an ACE or an ARB. You have to monitor their potassium levels. The potassium levels oftentimes creep up when the renal function is decreasing. Monitor urine albumin to assess effect. This is the calcium channel blocker. The non-dihydropyridine calcium channel blocker actually helps proteinuria. So those are the non-hydropyridine of rapamycardazem that you want to get diabetics on because it decreases proteinuria. Or beta blocker if unable to tolerate an ACE or an ARB. Protein restriction is initiated when patient's GFR starts to fall. So when unhealthy kidneys, they actually lose their ability to remove protein waste, and this starts to build up in the blood. So that's why you put them on a restricted protein diet. So also the glomerular filtration rate of less than 60 is a sign that the kidneys are failing. And the kidneys problems, when they're less than 60, they actually damage at the nephron level. And what happens, you get kidney failure, you have too little blood that flows to the kidneys, and there's damage to the filtering units of the kidneys. And a male GFR should be normally 97 to 137, and a female normal GFR is 88 to 128. You want to refer to a nephrologist when the GFR is less than 60 and the serum creatinine is less than 60, or you have difficulty managing their hypertension, or they start developing hyperkalemia. Retinopathy, you want to have make sure they have a yearly dilated eye exam. You want to have them see ophthalmologist. Treatment for cardiovascular. You want to manage dyslipidemia with the new JC8 guidelines, not the ATP3 guidelines. It's the JC8 guidelines. Post-MI, you want to make sure that they're on a cardioselective beta blocker, carvedilol if they can tolerate it, or toprol, which is low pressor. This may decrease morbidity and mortality. Aspirin daily. You want to make sure that they quit smoking. With patients with congestive heart failure, metformin is contraindicated because of the lactic acidosis. You want to caution the use of thalazoledine, better known as TCDs. Those medications like Actos or Avandia are associated with fluid retention, and there's many studies that show there's an increased risk for coronary heart disease and heart attack when these patients are on TZDs. So CHF with metformin, the majority reports those combination causes an increase of lactic acidosis. Neuropathy, this is really, really important. Diabetic foot care, podiatrist every 60 days. A lot of these patients have painful neuropathy. They're also treated with tricyclic antidepressants that help the pain, like Elavil, Neurontin, carbamazepine, Tegretol, or associated capsaicin cream to the area, which is like a numbing cream that helps pain. Treatment of complications. In the autonomic nervous system, patients who are diabetic oftentimes have gastroparesis, which is really a real deal with someone who's a diabetic. And gastroparesis is signs and symptoms of nausea, undigested food, feeling of fullness, early feeling of fullness when eating, occurs when nerves to the stomach are damaged and they stop working. And remember that vagus nerve controls the movement of food through the digestive tract, and that's part of the autonomic nervous system's patients lack appetite. So patients who have gastroparesis, we want to get them on Reglan. Patients can also have diabetic diarrhea, and that's autonomic neuropathy. And this autonomic neuropathy is caused by nerve damage that controls involuntary activities of the body, which are most commonly known types of autonomic neuropathy, which include erectile dysfunction, orthostatic hypotension, diarrhea, feelings of lightheadedness, dizziness, and so forth. Selenium is used for a laxative, or clonidine is another one as well. Impotence, we use Viagra or Cialis, or penile injections, which is very common with diabetics. Overflow, incontinence, we use urocholine, which is a parasympathetic mimetic agent, and it's administered to treat gastric and urinary retention. This basically makes stomach emptier faster, or i.e. urinary retention. Helps urinary retention. Major classifications of medications: drugs that sensitize the body to insulin or control hepatic glucose productions. Those are Biguanides or thalazonidines, TZDs. Thalazonidine. And these, you have to know these. These two drugs sensitize the body to insulin or control hepatic glucose production. You have to memorize these mechanisms. Drugs that stimulate the pancreas to produce more insulin, Meglitinides and Sulfonylureas, and drugs that slow the absorption of starches, i.e. carbohydrates, are Alpha-Glucosidase Inhibitors. Medications by Biguanides. Medications in this class include glucophage, glucophage XR, metformin extended, mechanism action, decrease hepatic glucose production, increase insulin-mediated peripheral glucose uptake. The efficacy: decrease fasting plasma glucose to 60 to 70 and actually reduce hemoglobin A1C to 1 or 2. These can be used as monotherapy or in combination with the sulfonylureas, so you can prescribe metformin and sulfonylureas together. When metformin is used with monotherapy, it does not cause hypoglycemia. So some of the advantages of biguanides are they're weight neutral, they're cheap, they're well tolerated, they may offer endogenous suppression in PCOS or metabolic syndromes. The disadvantages are they're cleared through the kidneys, okay? So if there's any renal failure, these probably aren't the best choice. There's GI effects that can be severe in some people. They may worsen hyperglycemia in some people. Patients who need CAT scans or cardiac cath or anything with a contrast dye, this may cause patients to go into renal failure with a combination of this and the contrast. Biguanides, some of the side effects are diarrhea, abdominal discomfort, lactic acidosis if improperly prescribed. They actually can have a small decrease in LDL and triglycerides, no weight gain, possible moderate weight loss. What you need to monitor yearly is hemoglobin, hematocrit, red blood cell indices, and renal function. Biguanides should not be prescribed in patients with renal failure because of the lactic acidosis. Lactic acidosis is life-threatening, a condition that is fatal in 50% of cases and is caused by too much lactate in the blood and low pH of the blood. Several factors can increase the risk of lactic acidosis when you're taking metformin, while taking metformin. And those really, the big ones are having kidney problems or congestive heart failure. Special considerations with biguanides: they're contraindicated in patients with impaired renal function. So a serum creatinine of greater than 1.4 for women or 1.5 for men. You want to hold the biguanide or metformin 48 hours to the IV contrast injection. Normal renal function should be confirmed 48 hours after IV contrast before restarting therapy. Basically, is their creatinine, and GFR okay before restarting the metformin after the contrast dye for like a chest CT. Any CT that you're ruling on an abscess requires contrast as well. Tagamet, which is hardly ever used, causes decreased renal clearance, can lead to 40% increased level in metformin levels. Lactic acidosis occurs in patients who take biguanides and also who have hepatic dysfunction, severe illness, patients who drink lots of alcohol, or are hypoxic. Available 500 milligrams, 850 milligrams once or twice daily, should be taken with food, and the total dose should not exceed 2,250. Remember, contrast dye can cause kidney failure, especially if the person is taking metformin. TZDs or medications in this class are Actos, Avandia. The mechanism of action, you need to know. They decrease insulin resistance by making muscle and adipose tissue more sensitive to insulin. They suppress hepatic glucose production. The efficacy is they decrease fasting plasma glucose 35 to 40. They reduce hemoglobin A1C to approximately 0.5 to 1.1%, and it takes about 6 weeks for the maximum effect. Okay, so TZDs are effective as monotherapy, second line, or in combination with insulin, okay? Metformin or sulfonylurea. So TZDs like Actos or Avandia are effective as monotherapy, second line, or in combination with insulin, metformin, or as sulfonylurea for treating type 2 diabetes. Side effects for TZDs are weight gain, edema, hypoglycemia if taken with insulin or agents that stimulate insulin release. They improve HDL and triglycerides, and usually they're LDL neutral. The contraindications and precautions: impaired hepatic function, congestive heart failure, anemia. These can cause patients pregnant, especially women who are postmenopausal who do not think they can get pregnant. They can also cause hypoglycemia. If there's impaired liver function, this patient should not be started on patients with active liver disease or an ALT of greater than 2.5 times the upper limit of normals. LFT should be checked prior to initiation and then every 2 months for the first year and periodically thereafter. So with TZD, it causes plasma volume expansion, which is absolutely awful with congestive heart failure. Okay? Plasma volume expansion, we don't want to do that in people with congestive heart failure. Anemia, it's possibly due to dilutional effects due to the increased plasma volume expansion. And postmenopausal pregnancy, it basically may cause the ovulation to resume. So you have to tell women to use contraception. Hypoglycemia, patients treated concomitantly with insulin or sulfonylureas. So if the patient's on a TZD with insulin, then they're at risk for hypoglycemia. The benefit of TZDs, they're well tolerated in renal disease. Okay, they're well tolerated in drawbacks. There's long-term safety concerns with persistent treatment of TZDs. Edema, weight gain is one. Exacerbation of cardiac disease is also a concern. CHF, liver disease, and also there's a link between TZDs and bladder cancer. Sulfonylureas, medications in this class, these are the first generations of medications, which you're not going to be prescribing, but no, first generation, they're not used really. Second generation, the Glycemics, the Amorol, the Glipizide. So the first line choice therapy for monotherapy is metformin. Metformin, first line therapy for monotherapy, metformin, especially with lean or non-fat patients. Sulfonylureas is the first line choice therapy for monotherapy, especially with lean patients. So the first line choice for patients who are obese are metformin. Sulfonylureas can be used with insulin, but it's not a good practice to use it with insulin because insulin and sulfonylureas can actually deplete beta cells. So oftentimes, if they're on sulfonylurea and say metformin, and they needed to be transitioned over to insulin, they'll stop the sulfonylurea and keep them on the metformin. So sulfonylureas can be used with insulin and all other oral agents except Meglitinides. They cannot be used, sulfonylureas cannot be used with Meglitinides. So the mechanism of action for sulfonylureas is increases endogenous insulin secretion. It's ineffective in patients without endogenous insulin. The efficacy, it decreases fasting blood glucose from down to 60 to 70. Okay, so you can come, if their blood sugar is 180, you can bring them down 60 to 70 points. So it decreases fasting plasma 60 to 70, reduces hemoglobin A1C by 1 or 2, generally the least expensive class. This is the best option for type 2 diabetes before the age of 40. if the duration of disease is less than 5 years before initiating drug therapy, and really a good choice if the fasting blood glucose level is less than 300. Side effects are hypoglycemia, weight gain, nausea, and diarrhea. It has no specific effect on plasma lipids or blood pressure. You want to be very careful and cautious with renal and patients with renal and hepatic disease, hypoglycemia, loss of control of blood glucose, and sulfonylureas have many drug interactions. Glucotrol is available in 5 to 10 milligrams daily. The maximum dose is 40 milligrams a day. Glyburide is 1.2, 2.5, and 5 milligram tablets. The maximum dose is 20 milligrams. It's more potent than glipizide. Renal and hepatic disease, they have slowed metabolism, so they're at risk for hypoglycemia in elderly, debilitated, malnourished individuals with perhaps adrenal or pituitary insufficiency. Loss of control of blood glucose are some of the acute reasons or long-term due to secondary failures. Most patients fail monotherapy with sulfonylureas within 5 years, meaning they have to transition over to insulin. That's an important piece to tell patients, that you most likely will need insulin within 5 years. If patients are drinking alcohol, they're at increased risk for hypoglycemia and this. Also, if they're taking nonsteroidals, salicylates, sulfonamides, chloramphenicol, MAOs, beta blockers, or insulin, which you shouldn't really prescribe sulfonylurea and insulin. You can, but it's not recommended. Hypoglycemia occurs with thiazides and other diuretics, steroids, thyroid products, estrogen, over-the-counter, oral contraceptives, Dilantin, any sympathomimetics, and calcium channel blockers can cause hyperglycemia. Meglitinides, medications in this class include Prandin and Starlex. The mechanism of action, which you need to know, is they stimulate insulin secretion in the presence of glucose rapidly for a short duration. Stimulate insulin secretion in the presence of glucose. Okay, the mechanism of action is similar to sulfonylureas, so you do not want to use meglitinides with sulfonylurea, because there'll be a dramatic dip in blood sugar. Meglitinides are indicated for monotherapy or in combination with metformin or TZDs. So Prandin dosing is taken before meals, 0.5 to 4 milligrams, may be useful in patients with sulfur allergy or renal impairment. And Starlex dosing taken BID 3 times a day before meals, and the dosing is 60 milligrams to 120 milligrams before meals TID. The efficacy of meglitinides decreases peak postprandial glucose, decreases plasma glucose 60 to 70, reduces hemoglobin A1C from 1 to 2. The side effects are hypoglycemia, less than with sulfonylurea if patient has a variable eating schedule. There's also side effects of weight gain, nausea, vomiting, diarrhea, and constipation can occur. No significant effect on plasma lipid levels. They're safe at higher levels of serum creatinine than sulfonylureas. Special considerations for Prandin: rapid onset of action, taken with meals 2 to 4 times a day, suitable if there's an allergy to sulfur and cannot take sulfonylureas. This can be used as a monotherapy or in combination with metformin. Titrate slowly in elderly or those with hepatic or renal impairment. These are contraindicated in individuals who are hypersensitive to meglitinides. They're insulin dependent. They have a history of diabetic ketoacidosis, and they have liver failure or dysfunction. Be used cautiously in patients with hypoglycemia. Replacement with insulin may be necessary during stressful times. And the loss is also the loss of glycemic control due to secondary failure. Alpha-glucosidase inhibitors, mechanism of this class are glycet or precose. Mechanism of action is blocks the enzyme that digests starches in the small intestine. Special consideration, dose dependent on if the patient has liver dysfunction or hepatotoxicity. Suitable to binding with other agents, susceptible, meaning it can bind with other agents and be dangerous. Question, take 2 to 4 hours apart to avoid interaction with alpha-glucosidase inhibitors. This medication is used as a second-line therapy or in combination with sulfonylureas or metformin. There's also a note that there's poor patient compliance due to GI symptoms. The efficacy of alpha-glucosidase inhibitors, they decrease peak postprandial glucose from 40 to 50. They decrease fasting plasma glucose from 20 to 30. They decrease hemoglobin A1C from 0.5 to 1. The side effects of flatulence or abdominal discomfort, low serum iron, which is meglitinol, will be the one that does that the most. Reversible hepatic enzyme elevation, acarbose is the one that does that. No specific effect on lipids or blood pressure. No weight gain. It's contraindication in patients with inflammatory bowel disease or cirrhosis. Other contraindications are partial bowel obstruction, inflammatory bowel disease, colon ulcerations, absorption or digestive diseases, or diabetic ketoacidosis. You want to be cautious with hypoglycemia when there's a serum creatinine greater than 2, and you want to monitor liver function tests. 1/3 of the patients who start alpha-glucosidase inhibitors will stop using these drugs due to GI side effects. So you have fixed dose combinations with sulfonylureas and biguanides, which are glucovance, metaglip, and TZD plus biguanide, which is Abdamet. Also, the combination of ogliptin plus metformin, just remember that, ogliptin plus metformin, which is not on the sheet, but is used a lot, and you'll see it in practice, is ogliptin plus metformin has significant interactions. Drugs that may potentiate effects of sulfonylureas, salicylates, cofibrulates, warfarin, alcohol, ACE inhibitors, thiazide, and may impair glucose intolerance. So the combination of those two has significant interactions. And drugs that may potentiate effects of sulfonylureas, salicylates, cofibrates, comedin, alcohol, and ACE and thiazide diuretics. Medication, Incretin Mimetics. Basically, Incretin Mimetics, they basically improve insulin secretion in diabetics. So what they can be DPP4 inhibitors, and what happens with the Incretin Mimetics medications in that class are Byetta or Victoza. They're injectable synthetic peptides that mimic Incretin or GLP-1. And this is rapidly inactivated in the blood enzyme called DPP4 or DPP4 inhibitors work by stopping the breakdown of GLP-1. This makes GLP-1 last longer and in turn increases the level of GLP in your blood. The DPP4 inhibitors may be used alone or in combination with other anti-diabetic drugs. These drugs are fairly well tolerated by most patients, have minimal side effects, and are usually not associated with weight changes during therapy. So when are Incretin mimetic-based therapy used? Both Byetta and DPP-4 inhibitors may be used in people who are poorly controlled diabetics. They are used alone or in combination with other anti-diabetic medications. They both lower blood sugar levels, and in addition, Januvia may be associated with some weight loss. And Januvia actually increases the insulin that's made by your pancreas when blood sugar is high. And it reduces basically the amount of sugar that's made by your liver. And all of these improve insulin secretion in the diabetic. So Incretins, the benefits, they improve postprandial control, they reduce appetite, they improve insulin sensitivities, they delay gastric emptying, they improve beta cell function, they don't cause hypoglycemia, and there's a weight loss on average of 2.4 kilograms. Drawbacks is the nausea can be severe, it's an injection, patients can be constipated, patients who are diabetics can have worsening gastroparesis, may exacerbate hypoglycemia, pancreatitis is a risk, and also thyroid cancer. These drugs are expensive. DPP inhibitors, medication in this class is Januvia. Indication is not adequately controlled on metformin, sulfonylureas, or TZD. Mechanism of action inhibits the breakdown of GLP-1 in the bloodstream. Side effects are stuffy, runny nose, upper respiratory infection, or headaches. Patients who require insulin therapy and type 2 diabetes. And these are indications when patients have significant hyperglycemia at presentation. They have hyperglycemia on maximal doses of oral agents. Surgery can be a cause to control and why people need insulin. Pregnancy, renal or hepatic disease, or decompensation. Acute injury, stress, infection, myocardial ischemia. Severe hyperglycemia with ketonemia or ketonuria, which is ketonemia is ketones in the blood, and ketonuria is ketones in the urine. Uncontrolled weight loss, use of diabetic medications that cause diabetes, like steroids. So with insulin, when you segue from oral agents to insulin or just insulin, basically the intensive glycemic control typically cannot be maintained with oral agents alone. So we have opportunities for improvement, and really we need to understand the failure to aggressively treat to achieve goals. We have to think that these patients that we have sustain elevated hemoglobin A1Cs for too long, and this can cause target organ damage. The average person sustained a hemoglobin A1C of greater than 8 for over 5 years, and the average person sustains a hemoglobin A1C of greater than 7 for over 10 years. So the goals are to maintain near normal glycemia, avoid short-term crisis, minimize long-term complications, and improve patients' quality of life. So the basal versus bolus insulin concept. Basal insulin suppresses glucose production between meals and overnight, 40 to 50% of daily needs. The bolus insulin is mealtime. This limits hypoglycemia after meals. Immediate rise and sharp peak at 1 hour. 10 to 20% of total daily insulin requirement at each meal. Basal versus bolus. Bolus or mealtime insulin are Novolog, Humalog, and Novolin. Basal insulin are NPH, Lente, Ultralente, or Lantus, or Livomere. And these are just, you're going to be expected to know the peak of Lantus, the peak of NPH, and the peak of regular. These are combinations, 50% of NPH, 50% of regular, the onset and the peak. These are combination insulins, 70 of NPH, 30 of regular. Also, 75% of Humalog, 75-25. Also, 70% Novolog, 70-30 versus Humalog, 75-25. In general, patients with a hemoglobin A1C greater than 10 need to be on insulin. So in general, patients with a hemoglobin A1C of greater than 10 need to be on insulin. So patients who no longer have beta cell function require a basal bolus insulin regimen. And usually it's NPH BID or daily dose of Lantus, combined with short-acting insulin pre-meals. So insulin added to oral therapy, you want to add 10 units of basal insulin at bedtime, NPH or Lantus. You want to continue current oral agents, which is, there's some controversy, especially with sulfonylureas. If control is still subtherapeutic, add or change to daytime injection of NPH or Lente, 75-25 or 70-30. This should be initiated in a dosage of 10 to 25 units a day. So insulin therapy is a first-line treatment for type 2 diabetes with an A1C of greater than 10 and a glucose range of greater than 250. Most common reason to go from insulin is a failure to respond to oral anti-hypoglycemic agents. Typical scenario with type 2 and elevated fasting glucose, most likely you'll order NPH 5 to 10 units or 10 units of Lantus or Livomere taken at 8 to 9 p.m. at night, along with oral agent during the day. If the control is still subtherapeutic, then a daytime injection of NPH or Lente, 70 to 30 mix should be initiated at a dose of 10 to 25 units a day. The only reason you should change to a mixture is to prevent the patient from being confused. In general, the starting dose at bedtime is less important than having a titration algorithm. Typically, start at 10 units or 0.1 to 0.2 units per kilogram. Most patients will end up needing 0.5 to 1 units of kilogram per day. Also, a typical titration can be done every 2 to 3 days by the patient until fasting plasma glucose reaches 100 to 120. So, for example, if a patient's fasting blood glucose is 100 to 120, they will require no adjustment in their dose of insulin, in their daily dose of insulin. If their fasting blood glucose is 120 to 140, then you increase their daily dose of insulin to 2 units. If they have a blood sugar of 140 to 180, then you increase it 4 units. If their blood sugar is greater than 180, they're fasting. We're talking about fasting, this is fasting. When they wake up in the morning, you increase their dose per unit per day, 6 units. So I have this is a treatment algorithm. This talks a little bit about nutrition, which you guys, it's real important. They need to see a nutritionist. You need to be familiar with this. You need to teach them about carbohydrates, the percentage, the protein, the fats, hyperglycemia signs and symptoms, and hyperglycemia. If you don't do it, you might be required as an NP. It depends on what your practice has available. Blood glucose monitoring are key. They have to come in and show you their readings. Medication and insulin administration, meal planning, exercise, and the prevention of long-term complications. That's like podiatry, eye exam, physicals. All those things are really, really important. Okay, so I missed this. Who gets what? Newly diagnosed. We're just going to newly diagnosed with glucose. So go back when you're studying for this and really kind of take a look. I'm going to give you the answers, but try to understand why I'm giving you the answers. So newly diagnosed with a glucose of greater than 250, what should they get? Insulin. Remember, they can bring 60% of patients with type 2 diabetics off of insulin eventually with diet and exercise changes. They might need that initially, but if they change their diet and they exercise, they might be able to come off that insulin. But initially, we have to put them on insulin if they have glucose level of 250, greater than 250. Prediabetes. What do we do with a person with prediabetes blood glucose level? We initiate and teach them how to do lifestyle changes. Renal insufficiency or renal failure. This type of patient gets Januvia. Can be used with end-stage renal disease, a creatinine of greater than 3, though dose is lower. 100 milligrams with no renal failure, 50 milligrams with a creatinine of greater than 3, a BUN 25. 4. Obese and newly diagnosed, start them on metformin. 5. Obese, metformin, Byetta, and maybe insulin. 6. High first morning glucose. You want them to eat breakfast and then start them on metformin. Someone who's a carboholic. Remember the alpha-glucosidase inhibitors. It blocks the enzymes that digest starches, and it also, which are taken at the beginning of meals to decrease postprandial hyperglycemia, the alpha-glucosidase inhibitors. Delayed gastric emptying, we want to give them Amorol, long-acting, take once daily. And 9, topped out on all PO medication, insulin, and if you start them on insulin, they need insulin, you might have to take them off. You most likely will take them off the sulfonylurea and may need to take them off the PO meds depending on how their blood sugars are with insulin. And that's the end for me today, guys. If you have any questions, we'll be going over case studies in class, and I know I'll be posting another supplement before the exam.